All right, so we're going to change directions and talk about stem cell mobilization. And this is an increasingly interesting area. And so the first question is, why is the bone marrow in the bone marrow? So it sounds sort of silly, but why do hematopoietic cells grow in the bone marrow and not anywhere else in the body? And when you're looking for hematopoietic stem cells, there are very few in the blood, but they reside in the bone marrow. Well, the obvious answer to that is the bone marrow provides a nurturing microenvironment that keeps the stem cells there. So there's homing to the bone marrow, and the bone marrow contains the niches where the stem cells grow and proliferate, and then only in a controlled fashion do the blood cells come out into the bloodstream and egress into other tissues. And the stem cells themselves physiologically traffic in and out of the bone marrow, which is their natural home. And then how can we as physicians and transplanters, how can we manipulate that to collect cells for transplantation? We can, of course, go back to the bone marrow and collect them by multiple aspirations. But in recent years, using peripheral blood transplants has been sort of a kinder and gentler way to get stem cells for transplantation, both on in terms of the donors, in terms of having them not need to go through an operation and multiple bone marrow punctures, and also for the recipients, because you can get a larger stem cell dose now with the mobilized peripheral blood than we could get from a bone marrow transplant. So this is sort of a simplistic view of the stem cell niche. You got your hematopoietic stem cells lying within the context of the stromal cells in the microenvironment, and the characteristics of this niche is beginning to be shown. Osteoblasts and mesenchymal stromal cells are very important in this, and there's many interactions between homing receptors, such as BLA4. On hematopoietic cells and their ligands in the stroma. And one of the main ones that control the homing of cells to the bone marrow is the interaction between SDF1, stromal-derived growth factor 1 from the stroma, and CXCR4, which is on hematopoietic cells. And in fact, hematopoietic cells home toward SDF1. This is a chemotractic factor that draws cells into the bone marrow. And one of the ways that we can mobilize cells out of the bone marrow into the blood is to interfere with that interaction, and then that allows the stem cells to mobilize. So there's sort of two parts of things, two aspects of mobilization that we now can therapeutically manage. The first one, and the first agent that's been used for stem cell mobilization is G-CSF. So G-CSF doesn't specifically target CXCR4, but it activates, it binds to hematopoietic cells and hematopoietic stem cells, and it actually activates neutrophils. And neutrophils in the bone marrow express various enzymes, methyl proteases, neutrophil elastase, MMP9 is a metal protease, and these enzymes actually cleave the homing receptors present on the hematopoietic cells that attach them to the stromal cells in the bone marrow. And so once those homing receptors are cleaved, now the cell is released and can be mobilized into the blood. There's also interactions of G-CSF on the expression of CXCR4, and there's probably some secondary effects on this CXCR4 SDF1 axis that's present even in G-CSF mobilized cells. But that has been the way we would traditionally mobilize stem cells in recent years. And as we think about getting cells for transplantation, we want the process to be reliable, so we can collect cells reliably and easily, predictable, so you can know when to call a pheresis unit, tell them they're ready to collect the cells. You don't want to have any failures where people don't get enough cells to do the transplant. You don't want to have any major toxicities. You want to minimize costs. This is important all over the world, but certainly for us in the U.S. as well as here in Asia. And the last thing is you want to make sure you don't mobilize cancer cells into the blood, because if you do that, then those cells are reinfused into the patients, and we know from previous gene marking studies that cancer cells in the cell product can actually contribute to relapse in the patient. So there are a number of agents that have been proposed for mobilization. So again, the common one that's used universally is G-CSF. And it, again, indirectly affects this process. But the one that we're going to sort of focus on today is Plerixafor, or Mozobel, which is a specific inhibitor of the STF1 CXCR4 interaction, basically blocking this interaction, which then releases the cells into the blood. It can also mobilize cells by blocking the other homing receptors. Anti-VLA4 antibodies will do it. IL-8 will do it. There are other factors that can do it. And other drugs are in development that might act on other parts of this axis. So we generally think of CD34 positive cells as the stem cells. The target of our goal is to mobilize these cells into the blood, but it's important to recognize that CD34 positive cells are themselves heterogeneous. In mice, CD34 is not a marker of stem cells. It's actually activated on up and down on stem cells, but isn't the same as it is in humans. But in humans, the stem cells are part of the CD34 positive subset, and they're actually this subset. So the pluripotent hematopoietic stem cells are typically CD34 positive, CD38 negative, and negative for all the other differentiation antigens. But as you go along various pathways, you develop other markers. So CD61 is on platelets and megakaryocytes. Myeloid markers, again, may appear, or lymphoid markers may appear on the cells that would then identify subsets of cells already predisposed to differentiate into those tissues. And so what we're really thinking about in terms of hematopoietic stem cells is this fraction, the CD34 positive, 38 negative. In practice, the total CD34 number gives us a pretty good working handle on stem cell dose in a product. And around the world, we don't bother looking at these subsets because they're small and it's not very reliable to be doing flow cytometry to try to enumerate them routinely. And that the total CD34 is still a pretty good marker for an adequate transplant. So one of the questions that always comes up is, you got your patient, you're giving them G-CSF, and you want to know when should you start the pheresis. And so if you look at the peripheral blood white blood count and the number of CD34 cells that you collect, there's not a real good correlation between the white blood count itself and the collection of CD34 cells. And so it's much more useful to measure CD34 cells in the blood, and actually we do this. And so we'll take patients, we'll give them Dupuytren for 4 days, we measure the CD34 level in the blood, and if it's over 10, then we know we're going to get a yield of more than 1 million CD34 positive cells per kilo, and we'll go ahead and do the pheresis. If it's less than 10, we know we won't. And we'll come back later to how one might use Plerixafor in those patients to try to boost that dose. But there's a correlation, as you'd expect. The more CD34 positive cells are in the blood, the greater their frequency, the more you're going to collect by pheresis. And so you can use that as a trigger to know when to start the pheresis. So you don't want to waste the people's time doing the pheresis, collecting cells if there's no stem cells in there, and waste the time of people in the laboratory freezing away cells that aren't going to help you. So anyway, how many stem cells do you need for transplant? So this is actually an age-old question, and there isn't a good answer. We don't really know the minimum number of stem cells. In principle, one good pluripotent stem cell would be all you need. You might need a year for those cells to grow, but in practice, we know that the higher the number of CD34 positive cells, the faster the recovery. And it's actually not neutrophils that is the most sensitive factor. It's platelets. So if you look at the recovery of platelets related to the cell dose, and here this gives you days, 7, 14, 28 days, and the number of CD34 positive cells per kilogram that you infuse, you can see that there's a dose-dependent increase in the rate of platelet recovery. And so 1 million per kilo, you get engraftment, but it's slow, and not everybody makes it up to full recovery. If you give 2 million, it's better. If you give 5 million, it's really good. And if you give 10 million, now it's marginally better, but you really don't get that much extra benefit from that extra dose. And so this was a study by John Glaspie many years ago, and this really has been sort of the basis of the general recommendation that you shoot for 5 million CD34 positive cells per kilo, because this gives you rapid engraftment of platelets and other hematopoietic cells, and it's a reasonable target that you can reach in most patients. But you can see that 1 million, you will recover in most cases, and most centers will use either 1 or 2 million as the dose. You say you got to have that dose, or we won't do the transplant. We ourselves use 2 million. So if you don't have 2 million CD34 positive cells, we stop, and then we'll think about how can we get more cells, or does the patient need some other form of treatment. And so what's the importance of the cell dose? So if you give low doses, intermediate doses, or high doses, you can see the percent of people who recover their platelet count goes up. So with the low dose, only half of the people at 1 year have recovered platelet counts of 150,000. You can see higher doses in the middle there. And in both lymphoma and myeloma, you see the same trends. So again, our goal is to try to get 5 million if we can, but we'll take 2 million if that's the best we can do. So we've talked about that. So the higher the cell dose, of course, the more it costs to collect the cells, but also there's a positive benefit on the recovery of the patients and their use of hospital resources after the transplant. So this is a retrospective analysis looking at the cost of the transplant in people who are good mobilizers or bad mobilizers. And you can see the bad mobilizers are less than 2 million, and the good mobilizers are more than 2 million. And as you'd expect, if you have slow hematopoietic recovery, you need more transfusions, you're probably going to have more infections, you have to stay in the hospital longer. And so, sure enough, those that were poor mobilizers have a much higher cost of their care than people who are good mobilizers. And so it's worth it to try to collect more cells if you can, because you're in dollar terms here, you're spending $60,000 on those patients by giving them a low cell dose in terms of their overall medical costs. And you can see the length of stay. Here it is, 1 week longer if people get a low cell dose compared to a good cell dose. So how do you best do this in terms of collecting stem cells? Well, there's sort of two general approaches for autologous collection. One, you can give chemotherapy, because chemotherapy itself mobilizes stem cells, and that as you recover from myelosuppressive chemotherapy, the hematopoietic stem cells, CD34s, go up in the blood just as you're beginning to recover your blood counts. And then you can add growth factors to that and get a further boost. So this improves the yield of CD34 positive cells compared to just giving growth factors. But it costs money to give chemotherapy, and then you got to deal with the complications. People get fever, you got to follow their blood counts, you got to give them transfusions. And so what we do is we only use this approach when people need the chemotherapy anyway. And so for people with aggressive lymphomas, we don't want to stop for a long time and interfere with their chemotherapy to collect their stem cells. We want to try to integrate the stem cell collection in their management of lymphoma. So we piggyback the collection procedure to their last dose of intensive chemotherapy before the transplant, and we use that both to collect more cells and to not have any major delay in their lymphoma treatment. Now, on the other hand, the sort of most cost-effective way to do the collection is just giving growth factors alone, so you don't have to pay for the chemotherapy, you don't deal with chemotherapy complications. And we do this in myeloma, which is a slower disease, and you don't have quite the urgency to keep the chemotherapy going on a rapid schedule. So growth factors alone is simple, it's efficient. When you start it, in 4 days later you're going to collect the cells, so it's predictable. It provides an adequate CD34 yield in most, but not all patients. And it's less costly than doing the chemotherapy mobilization. And again, the downside is if you're needing chemotherapy, you have to interrupt chemotherapy or have some delay in chemotherapy that might allow the tumor to regrow as you're doing the mobilization. But we use this for myeloma, and again, we use this for aggressive lymphomas. So can you predict who's going to be a bad mobilizer? Well, there are some factors. So the older you are, nothing's good as you get older, unfortunately. And so you tend to mobilize more poorly. Mobilization regimens, again, have a difference in terms of their yield, and we'll talk about that. The amount and type of prior chemotherapy. So if you've had a lot of stem cell toxic drugs over the years, that's going to affect your ability to mobilize the patients. So alkylating agent exposure in the past. A big one now in myeloma is lenalidomide. Really good drug for myeloma, part of the frontline treatment, but it does suppress hematopoiesis. It does make it harder to collect stem cells, and radiation to the bone marrow is another big one. And one simple thing is your platelet count at the time that you start mobilization. If you start with more than 100,000 platelets, you've got a much better chance to collect your target cell dose than if you have a lower dose. This just shows you the effect of chemotherapy plus growth factors. And to make a long story short, if you get cyclophosphamide with your growth factor, the number of CD34 positive cells is generally increased. You can see by a factor of maybe 1.5 to 3-fold higher. So again, it's a way that you can mobilize better. And so in some patients that we think will be hard to mobilize, we'll give them chemotherapy, cyclophosphamide, or a more intensive regimen with their G-CSF, with myeloma, for example. And whereas people where we think we can mobilize easily, we would just give them growth factors alone. So one of the things in lymphomas is we use rituximab to treat their lymphoma, and there was initially concern that rituximab might adversely affect the mobilization of the stem cells. So rituximab has an advantage. It binds to B cells and it removes them from the circulation. So it's a way to in vivo purge the patient of having lymphoma cells in their blood, and then you won't collect them in your cell product. So it's a good thing to give Rituxan from that perspective. We actually were happily surprised that there wasn't any impact on mobilization of stem cells. We were worried about that because some people with get Rituxan become neutropenic, and there's some interaction between B cells and neutrophil production that's not well defined. But if you've used a lot of rituximab, you know that some of your patients will have sort of unexpected and prolonged neutropenia related to that treatment. But in our study in lymphoma patients, we didn't see an impact on stem cell mobilization, especially with chemotherapy mobilization. And we've had improved results of the transplant when we used Rituxan both in the mobilization and in the transplant regimen. So this is historical controls data. People got BEAM before the era of Rituxan, and here is BEAM when we've given Rituxan with the mobilization and the transplant. And this is large cell lymphoma. And you can see a dramatic improvement in the progression-free survival of patients where Rituxan is involved. Now, this has gotten more complicated as time goes by, because now everybody gets Rituxan for all of their course of treatment. And that in the Rituxan era, the results of autologous transplants are actually somewhat worse. And that's probably because now we're treating Rituxan-resistant patients. And this study had been done sort of in the interface time when Rituxan was just coming onto the market. Now, we think it does prove the principle that Rituxan is valuable both as part of the mobilization and the transplant regimen. All right, we've talked already about these adhesion molecules and mobilization. And what we want to do now is turn to this CXCR4 SDF1 interface. And again, the bone marrow stromal cells make SDF1. It attracts hematopoietic stem cells into the bone marrow microenvironment, where then they bind other homing receptors and integrins that actually hold the cells in there. And that when you give Plerixafor, it mobilizes cells into the blood. And it's actually interesting because it's got a totally different kinetics than G-CSF. When you give G-CSF, excuse me, you got to wait 4 days for the neutrophils. Well, neutrophils go up right away, but the stem cells take 4 days before they're mobilized into the blood. Now, on the other hand, when you give Plerixafor, they go up right away. Just within a few hours, they go up, and then they'll come down roughly a day later after a single dose. And so so as we use the two drugs, we have to use them in different ways. For G-CSF, you got to start 4 days before the collection, but Plerixafor you can give right away. So it does work as a single agent, and it's synergistic with G-CSF. It actually doesn't mobilize as well as a single agent as G-CSF does, but it's very synergistic with G-CSF. So you get a marked increase in the number of circulating CD34 positive cells. And then you get that increases your likelihood then of having successful mobilization and collection of the patients. And so the harder to mobilize patients now will have more cells in the blood, and you'll get a higher cell dose. And as we showed earlier, that results in a better transplant, both in terms of engraftment, costs, and then outcome. And so one of the questions is as we use the Plerixafor, does it change the graft? Does it change the stem cells that we collect? Is it worth it? Is it worth the added cost of the agent, because it does cost money? And what's its effects on malignant cells? So we'll come back to those. So interestingly, the stem cells that you get are a little bit different with the Plerixafor mobilized cells. And you can see here Plerixafor and G-CSF, G-CSF alone, or Plerixafor alone. And you see the array map here in terms of gene expression, and you can see they're different. So you're somehow inducing a different program of gene expression in CD34 positive cells by use of these agents. And we're still trying to sort this out. Does this have any practical significance? The simple answer is no, that the CD34 positive cells seem to function the same as any other CD34 positive cell. And no matter how you collect them, if you have an adequate cell dose, people have engraftment, pretty much as I showed you, related to the number of cells infused. So there's certainly not a defect in those cells. And in fact, there might be some advantages in terms of mobilizing a more primitive population of cells that might, in some contexts, be an advantage. So the other interesting thing is that you get a different mobilization of T cells and immune cells. So you get more T, B, and NK cells with the Plerixafor mobilized grafts. And you actually get mesenchymal stromal cells as well with Plerixafor that you don't get with G-CSF. So there is some functional differences between the two, and those might in fact prove valuable for allogeneic transplants, although there isn't much data there. So this drug has really been primarily studied and used in people getting autologous stem cell transplant, but we're very interested in its potential use for allo transplants. So here's just a comparison of mobilization. This was in normal donors, just to show the biologic effects in normal people, where you don't have to worry about the effects of patients' malignancy and their prior chemotherapy. So these are normal donors. So people who got Plerixafor or G-CSF in a study by Steve Devine, where they were used for an allogeneic transplant, you can see the peak CD34 numbers are actually higher with G-CSF than with Plerixafor. And so the total CD34s are lower. But interestingly, again, the T cells are higher. Here you can see CD3, CD4 positive T cells, and even CD8s, although this is not significant. They're all higher with Plerixafor than with G-CSF. And NK cells, this is CD56, are also higher. So not quite as many CD34 positive cells. And so generally it's not given as a single agent, but it's given with G-CSF because you see synergistic increases in the total CD34 number. What about cancer mobilization? Well, this is still a big question. And that because hematopoietic malignancies and solid tumors are virtually all express CXCR4 on their surface. And so one of the questions is, would the use of Plerixafor, would it lead to release of tumor cells? And that could be good or bad. We actually are studying this as a way to try to sensitize leukemia cells to being killed by chemotherapy, because if we liberate them from the protective effects of the microenvironment, they become now more sensitive to chemotherapy. And this may well be an adjunct to chemotherapy treatment of AML. On the other hand, for autologous transplants, we're of course concerned if you release tumor cells into the blood, you'll collect them with your transplant. And but to date, this has not had any practical effect on the outcome of the transplant. So people who have gotten transplants for lymphoma and myeloma where Plerixafor has been used, we have not seen an increase in relapse rates. But this, again, is something that is going to be watched over time. So it often comes down to considerations of cost and how much money do you save if you can reduce the number of apheresis procedures you can do. So if you just hypothesize here, say you're going to use G-CSF and you're going to need 2 collections to get all the cells you need, or you could give G-CSF and Plerixafor and you might get all the cells you need in one apheresis. So by cutting back on one apheresis, we looked at the cost of all the things that have to be done to get the patient ready for their apheresis, to conduct the apheresis, to freeze the cells. And the bottom line is we save $3,826 if we can avoid doing a single apheresis. And that's roughly the cost of the drug. And so if you can reliably reduce the apheresis cost, it's worth it to give the Plerixafor. And it also helps you. So in our apheresis unit, we're very busy. It's crowded. We don't have room to take care of all the patients that we have. If we can free up a apheresis bed on a given day, then it helps us. And the same thing for the stem cell lab. They don't have as many products that they have to freeze, and we'll be able to treat the same number of patients. So so how do we function internally when we're collecting cells? Well, for the autos and the allos, our goal is to get 5 million CD34 positive cells per kilo, and we accept a minimum of 2 million. So again, if we say you don't get 2 million, that's not enough for a transplant. So if on our first day of collection, if we get more than 4 million, we just stop, because again, that's almost as good. If we have to do, so if we'll do 1 or 2 collections to shoot for that number, if we do a third collection and we get 3 million, that's good enough, and we'll stop. If we do 4 collections and we get 2 million, then we finally stop. And because you get diminishing returns as you keep going on and on and on, you get fewer and fewer cells. So, and we'll do the apheresis if there's 10 CD34 positive cells per microliter in the blood. Excuse me. And so we'll measure that in the morning before we start the apheresis. And if we see that we just can't get enough cells in the blood, then we'll basically, if we have less than 10, then we'll give Plerixafor, basically to boost the mobilization and then collect the cells. So in myeloma, because tandem transplants are used, or transplants later in the course of the disease, we actually collect cells for 2 transplants, and basically we just double those numbers. So we try to shoot for, again, our goal is to get 6 to 8 million per kilo for 2 transplants, and so basically it basically doubles the number of cells that we want to collect. So one of the ways that many centers use Plerixafor, again, because you're adding the cost of the drug to your mobilization procedure, is to use G-CSF alone if it works. So you give your G-CSF, you got plenty of cells, you just go ahead and collect, and you're done. And on the other hand, if you're not getting a good collection, you can then add in Plerixafor, because it's synergistic with G-CSF, increase the number of cells, and that will allow you to collect cells in these harder to mobilize patients. And so this is an approach to use the drug when you need it and not have the expense of the drug when you don't need it. And we use the circulating CD34 on day 4, the day before or the day of the collection, to determine who needs the Plerixafor. So again, we can often predict who's going to need it by their factors. So if you had high numbers of prior courses of chemotherapy, people who are female tend to mobilize less well than males. Prior radiation to the bone marrow, a low pre-mobilization platelet count, or if you've ever had bone marrow disease, then those are factors that would make it very likely that you're going to need Plerixafor, and we're ready to give it. Indolent lymphomas that have received a lot of fludarabine or other marrow suppressive treatments are hard to mobilize. And people that have a low CD34 positive count before starting the mobilization also are at high risk to have failure. Now, we actually haven't found this particularly useful, so we don't bother checking CD34 before we start the mobilization. We check it during the mobilization to see if the patient is ready for their collection. Now, it's different diseases and their prior treatments then lead to a different rate of poor mobilizers. So myeloma before lenalidomide was a good disease, because the initial treatments that were used, including Velcade, bortezomib doesn't suppress hematopoiesis very much, and we'd collect cells very easily on those patients. But now with the use of lenalidomide, that does make it more difficult to collect stem cells, and now about 15% of people we can't mobilize easily, and they need the Plerixafor. And in lymphomas and Hodgkin's disease, it's even higher. So they receive a lot of prior chemotherapy that's myelosuppressive, and so a quarter to a third of those patients will be poor mobilizers, and just with G-CSF alone, you'll fail to get your 2 million cell dose. So these people are the ones who clearly benefit from Plerixafor. And when you give Plerixafor, you can see you have a better chance of collecting your cells. So these are numbers of aphereses, and these are the percent of people getting their goal. And you can see the people getting Plerixafor, you basically double the chance of getting your desired cell type. So again, those people that you think you predict to be poor mobilizers, these are the people that clearly benefit from getting Plerixafor as part of their mobilization strategy. So to conclude here, hematopoietic stem cells and progenitor cells are mobilized by G-CSF and Plerixafor, a CXCR4 SDF1 inhibitor. The Plerixafor mobilizes PBE-PC, the peripheral blood progenitor cells, by interfering with that interaction. Plerixafor is synergistic with G-CSF, and the combination of the two drugs will reduce the number of aphereses required for stem cell collection and enhance the ability to collect the stem cells in hard-to-mobilize patients. And chemotherapy plus these growth factor combinations further enhances mobilization and is warranted when chemotherapy is indicated for the treatment of the patient's disease. So with that, I'll close. I'm happy to take questions. Thank you.
Professor Champlin, thanks for a very lucid presentation. My question is about the future of autologous transplantation. Because in this bortezomib era, where we are getting immunofixation negative CRs in myeloma, a question has arisen whether autologous transplant has a role in myeloma. And you're also saying that patients who have already received rituximab in aggressive NHL, they do poorly with autologous transplant. So how do you envisage the future of autologous transplantation in myeloma and lymphoma?
Right, so we in transplants are constantly in competition, if you will, with our colleagues in developing chemotherapy regimens that don't involve transplant, and so it's up to us to try to keep improving the outcomes that we can achieve with autologous and allogeneic transplants to reduce the morbidity and mortality and to reduce cost. Now, right now in myeloma, if you went to Dr. Geralt's presentation yesterday at noon, the people getting autologous transplants still have the best results. They still have the best time to progression of their disease, and we think it still has a central role in the management of those patients. Now, 20 years from now, will we be doing high-dose melphalan as treatment for myeloma? Probably not. But I think autologous transplant may provide a platform where we can give cellular therapy. So we're looking at ways we can add NK cells to an autologous transplant to try to develop an immune anti-tumor effect even in autologous patients. And other cell therapies can be given again, and you benefit from the lymphopenic environment. So when you give high-dose chemotherapy, you wipe out the patient's own lymphocytes, you give a lymphocyte infusion, and then those cells physiologically expand. So if you've got a tumor-specific lymphocyte, that cell will then expand to large numbers and increase the anti-tumor effect. So I think I'm very optimistic that autologous transplants are going to remain a key part of the management of myeloma, and that we can build upon that platform to improve the treatment of that disease. Now in lymphomas, even though we're getting harder patients now that more drugs are being used up front, including Rituxan, autologous transplant still is a standard of care for people with relapsed large cell lymphoma, and their randomized trials have shown improved survival with that approach. So again, the same thing holds true. We're going to need to work to continue to improve the results with autologous transplant, but it still is a core modality in the treatment of those patients. So I'm still upbeat on the future of transplantation. I tell our young fellows that they should work in this profession because we're going to be here a long time.
I have got two questions, please. What is the effect of bendamustine on stem cell mobilization? Do we have enough information?
We're using bendamustine now more and more. We actually use it in our transplant regimens, and so it is a myelosuppressive agent. It's the people with indolent lymphoid malignancies that are getting bendamustine also get fludarabine and other things, and so they're a hard to mobilize group. I can't really comment on bendamustine itself, how much more difficult it makes. but every one of those drugs, does, stress your bone marrow reserve.
Should we use it? And I mean,
yeah, well, it's a good drug. So our general principle is that people treating the cancer should use the best drugs that they can to get patients in remission. And if a patient's going to be predicted to need a transplant, we try to collect their cells early on before they get a lot of that treatment. So for Waldenstrom's patients, for example, before they get cladribine, which will suppress their bone marrows and make it hard to collect their cells, we collect and bank away cells before they get that treatment. And as we get more and more of these agents in indolent lymphomas, we may want to do the same thing there.
My second question pertains to mobilization in lymphomas with G-CSF alone versus chemo plus G-CSF. Are the results in disease-free survival different?
These are hard studies to do because there aren't like direct studies comparing that. We know that a general principle in aggressive lymphomas is to give chemotherapy in full dose and on time, because any delays in chemotherapy will get just regrowth of tumor. So as we've developed our program, we've tried to do just that. We've tried to use the patient's reinduction chemotherapy and collect as they're recovering from their last course of a rice kind of regimen. We actually just give Rituxan, ifosfamide, and etoposide as the regimen and leave out the platinum drug, since that's myelosuppressive, and try to do the transplant as promptly as we can with little delay. Because clearly, if you followed any of these people, you follow them for a short time and then they relapse, particularly with recurrent large cell lymphoma. So we want to have a minimum interruption in their treatment. And GCSF, if you give G-CSF alone again to large cell lymphomas, they're heavily pretreated. They have a limited marrow reserve. It's hard to get enough cells that you need, and then now you're really in trouble because you've taken a week, you tried to collect cells, you don't get enough, and now you got to do it again. And so we have just a much more reliable collection when we do this intensive treatment, and we tell the insurance company it's we're treating their disease, and then after that last chemotherapy, we're collecting their cells.
Dr. Champlin, when you combining Plerixafor with chemo-based mobilization, how do you decide the timing of the Plerixafor? Is it based upon the peripheral blood CD34s, or do you have a specific time?
So we look at the peripheral blood CD34s, and if their white count is coming up and they still have a low level of CD34, we will give Plerixafor to boost. Question in the back?
Is there any role of bone marrow harvest in poor mobilizers?
That's a good question. So we often, when you have a patient who doesn't mobilize, you're in and you don't have enough cells to do a transplant, you say, well, why don't we just collect the cells from the bone marrow? Now, often the people who have poor peripheral blood mobilization also have a hypocellular bone marrow that don't have a lot of stem cells there. And when we've done that, we've had some patients who've had graft failure after their transplant, even though we've collected and used their autologous bone marrow. So sometimes it works, but often it doesn't, and we're suspect that those patients would, even if we get CD34 positive cells, those are injured cells that just aren't capable of regrowing, and there's a high risk of graft failure when we use bone marrow. Now, what we generally do is we try, if we've given growth factor alone, we'll give chemotherapy and growth factors, including Plerixafor, in a second attempt to get peripheral blood stem cells. And if we can't get enough cells, then we just quit. But doing bone marrow, you would think it would work, but often you're collecting bad cells, and we still have problems with engraftment.
Can I ask you, no matter how you calculate it, the addition of Plerixafor adds more to the mobilization regime, even you take away the apheresis procedure, the bag, and so forth. Is there a strategy to, for instance, monitor the peripheral blood CD34 at certain days, and then if you don't achieve that particular count, you add on Plerixafor? And my actual question is that, is there a threshold that you see of peripheral blood CD34 whereby even the addition of Plerixafor is not going to work, or you know that if it's this particular number, like 5 or 6, you're able to get into a mobilization stage?
So we're sort of trying to fine-tune just how to do that. So again, if we're using growth factor alone, we give the Neupogen for 3 or 4 days, and then we often will check the CD34 level on day 3 or day 4, and then if it's certainly it's under 10, we give the Plerixafor. We're arguing whether, if it's say between 10 and 20, we should give the Plerixafor 2, because then we'll get all the cells we need with one collection. If it's more than 40, then you don't need to give Plerixafor because you'll have enough cells alone. And so again, it's an expensive drug, so we want to use it wisely.
Richard, over. So to your left.
Okay.
To your left.
Okay.
I wonder if I could just expand or get you to expand on your comments about the quality of the 34 cells collected. And certainly there's a lot of emphasis put on the total dose per kilogram of 34 cells infused on day 0. But what about the number of collections that it takes to achieve that dose? And are patients who require multiple attempts at mobilization or multiple rounds of aphereses, despite achieving a dose, actually doing less well because of the quality of the 34s collected?
Yeah, I think so. The general principle is that sick patients do worse than healthy patients, and people who are very slow mobilizers. You wonder both about the number of tumor cells in the blood as well as the quality of their stem cells. And in the early days of peripheral blood transplants, Jean Hester, if you know her from our center, we had some patients that had 17 aphereses that we'd finally get together enough cells to do a transplant, and often they would recover poorly. So I think that's true, and so we try to get all the cells that we need within a week of collection, sort of as our standard, and we try not to go beyond that point in terms of collecting just for that reason. Okay, well, thank you all. It's probably time for the meeting. You're just in time.